Good morning, everybody. Thank you for joining. I think we're going to kick off. It's dead on 10 o'clock, and I'm keen that we get started in order to keep to time. Please, can you ensure that you're on mute if you're not speaking, as it just stops the feedback on the line. And also it helps if you keep your video off as well until you're asking questions, but please do remember to switch them back on when you want to ask a question. There is a raise your hand function which you'll find on the toolbar. Now, I'm aware that having done other webinars and meetings, not everybody has that function. So if you do, feel free to use it and we'll know that you want to ask a question. If not, please also feel free to either unmute yourselves and ask, or to type any questions or comments in the chat box as well. And we'll capture that. Okay. Can I have the next slide, please? So just to start off with introductions, for those of you who don't know, I'm Liz Cullen. I'm Head of Clinical Programme for Maternity and Perinatal Mental Health for Hampshire and Thames Valley Clinical Networks. We've got another busy agenda as always, so quite a bit of content in terms of the national update this week, and thinking about our webinar in a fortnight's time, which will be on the long-term plan. Then Yvette is going to give us an update in terms of Webbeds and the perinatal mental health community teams page. Jenny, as our clinical lead, is then going to talk about hard to reach groups. And then we've got a guest speaker, Carrie Taylor, from Royal Berkshire, who's going to talk about partner support calls and thinking about partners and dads aspect of perinatal mental health. And then we're going to move on to our collaboration session with regards to restoration and recovery, and how do we capture some of those great initiatives that you've been doing, particularly during this COVID period, and thinking about what do we want to retain in terms of moving forward and picking up deliverables of the long-term plan as we over the next couple of months, and then thinking about next steps. And as I said, our next webinar in a fortnight's time on the 1st of July will be focused on the long-term plan, and Giles, the National Clinical Director, will be speaking at that webinar, which is great news. Okay, next slide, please. So I'll start off with the national update, and just to remind you that this information changes very quickly. So this is the latest information as we have it now, and as always, we will provide you and keep it updated throughout these webinars. Next slide, please. Okay, so I just wanted to remind us all, really, in terms of thinking about restoration and recovery. So most of the long-term plan ambitions have been kind of in a flex period at the moment, where there was the suggestion that they should continue if services were able to do that, but recognising that for some areas there needed to be a pause in terms of delivering the long-term ambitions. And some considerations which I think are quite important in terms of thinking about the flexible ambitions, and some of the areas we're going to talk about today. So thinking about the needs for certain psychological therapies and the training, and we're going to try and capture some of that training need that you may have as part of our collaborative session later on in the morning. Also thinking about the needs of partners and those accessing your services, and the kind of digital aspect of that. And obviously Kerry's going to talk about partners, Jenny's going to talk a little bit about the digital aspect of interacting with service users, and then also thinking about extending services to that 24 months period, maternal mental health services, and I'm going to give the latest update on that in terms of expressions of interest, which will be going out shortly, and then also in terms of needs of workforce. So just to remind us that those were the long-term plan flexible ambitions, but we will start to be ramping up on those as well as we go forward in terms of the restoration and recovery phase. Next slide, please. So this was something I just wanted to share in terms of what we have recognised, and I appreciate that the data falls off the cliff in terms of what we have on the 23rd of March, but just recognising that actually there was a massive drop in referrals into services in March as we went into lockdown, and it's just really to be mindful of that. And my anecdotal knowledge is that that has massively picked up again, but just thinking about what happens again if we were to go into a second surge, in terms of making sure that we are able to that people are able to access our services, but also that we are mindful of what is going on with our referral data. Okay, I'm going to move on from that slide. Next one, please. I wanted to highlight remote working, and this information isn't necessarily new to you, so I won't go through all of it, but it just highlights, as you're probably aware, and we've talked about previously on these seminars, that NHS England and NHS Improvement nationally procured Attend Anywhere for all secondary care providers as a video conferencing solution. There's been lots of different mediums available for trusts to take advantage of, and they've given IG guidance in terms of digital and video conferencing and that as well. But one of the things that I had picked up on a couple of meetings over the last couple of weeks since we last met was this £20,000 which is available of capital funding to support remote working, and that is available via the STPs. And I just wanted to highlight that, so that if you are having issues as a, can we go back up please? Thank you. If you're having issues in terms of accessing digital hardware, software, in terms of enabling that, please either get in touch with us and we'll put you in touch with the right people, or flag it up your system to the STP. So just wanted to highlight that really. Okay, next slide. I'm going to pass on at this point to Jenny, who's just going to talk about thinking about that digital new way of working, but making sure that we capture it in the right way in terms of data. Over to you, Jenny.
Hi, morning everyone. So what has come out of the data capture for from April 2019 until February 2020 is, if you look along this graph, only 29 captures of video conferencing in a whole year from all of the perinatal mental health services. So something is going badly wrong there. Whether you're miscoding it as telephone contact or just not capturing it properly, we're not sure, but there's definitely an issue, and that has to pick up. So if I can have the next slide. Thank you. It's just to make you aware of this code 03 telemedicine. So obviously this is aimed at our specialist perinatal teams, but that's the correct coding for video. So please make sure that you're doing that, because I know that all of you have been using a lot more video consultation, and we need to be able to capture that and show that. I also hear back from you that probably a lot of that's going to be kept going forward, so you absolutely need to be able to capture what you're doing. Next slide, please. And this is just to highlight that for those of us working in specialist teams, we'll all be aware of the ongoing battle we've had about whether we can count telephone contact. And there's a questionnaire coming out from the national team that's looking at the use of video and phone. And there's one for health professionals and there's one for patients, and they want you to be able to get that in front of as many of your patients as you possibly can. So once I think it's just gone out in its final draft for just a very, very final consultation, and that will be coming back quite quickly, and then we'll push it out to you as soon as we get it. I have to say the patient one is much longer than I would have liked, but it would be really helpful if you can get that to as many of your patients as possible. And I still think there's a case to capture some of your local things, so local reasons why women are refusing video, prefer the telephone, because this is going to be analysed as a national piece of work. So I don't think you'll be able to get local data back from it. So it'd be really helpful for your own services to have a bit of local narrative to support the use of the phone. Okay, so I hope that all makes sense, but do pop any questions in the box if you have any. And I'm going to hand back to Liz now. Okay, so I will see you guys again.
Jenny's already gone. Right, so I'm just going to cover what was maternity outreach clinics in terms of one of the LTP deliverables, but has now been retermed maternal mental health services, and just give you an update about that. I think firstly, and probably most importantly, is that there has been lots of debate about the terminology, about whether it should be called maternal mental health services and whether that makes sense and captures it, and there's still discussions going on at a national level, so it may still be renamed yet again, but currently that is the term for maternity outreach clinics. So the plan was for us to get up and running with maternity outreach clinics or maternal mental health services in order to offer mental health assessment and intervention for women experiencing mental health difficulties directly arising from or related to their maternity experience. So integrating maternity, reproductive health and psychological therapy. There was due to be a testing phase with selected sites that were due to start at the beginning of this financial year, so should have started in April, the process, but obviously was delayed because of COVID. And then the plan was to have fast followers coming online at a later stage in 21-22, and it was going to be funded centrally from transformation funding, mainly from mental health, the mental health national team, but some funding from the maternity transformation programme at a national level. And then going forward in 2023-24 financial year, it would be ultimately the funding would move into the CCG baselines, with an expectation, as in line with the specialist perinatal mental health community services, that there would be full coverage for the whole of England by that stage. So there had already been consultation events in terms of looking at the area of need, and both engaging with our service users and also healthcare professionals, and looking particularly at that area in terms of those women that wouldn't normally get seen by other services. They don't meet the criteria for other services. And their list there, I'll leave that for you to read in terms of some of the areas it would cover. Can we have the next slide, please? So this slide gives out the original proposed timeline, which is I just think is important to remind ourselves of in terms of thinking of future timelines that may be used going forward. So they had already developed an expert reference group. They had developed an expression of interest documents have been drafted, and looking at funding allocation. What they hadn't done yet was go out for the actual expressions of interest, so they hadn't launched that process. That got halted by COVID. So and then the timeline shows the different elements in terms of how it'd be a staggered approach to implementation. In the last couple of weeks, the national team have come out to regions to ask us how we think that we can get this up and running again, and how ready are our systems to start looking at expressions of interest and what have you. Can I have the next slide, please? And different scenarios were offered in terms of a recovery or restoration of the maternal mental health services. So one option was to basically just start in Q2. So to start in July, so literally things would have slipped by one quarter, And at that point, we would launch a call for both early implementers and fast followers. The second option was to slightly push things back. So to look at asking for early implementers in Q2, but that fast followers would take place at a later stage, so either Q3 or Q4. And the third option was to pause everything still and review again in another quarter as to what the situation was then. And I think from us, from Jenny and I having discussions with our services, also Barbara Goss from the regional team, it felt that those that were hoping to be early implementers were actually really ready to go and didn't want this to delay any further. And therefore, what we thought regionally was probably our best option, and we have fed back to the national team, was to go for option 2. So we would go ahead, be it a quarter late with early implementers, but have a pause and a bit of a gap, so get the early implementers started and then look for the fast followers to come on board at a slightly later stage, appreciating that there might be some more work that needs to be done in order to get the fast followers ready. Next slide, please. Okay, so this is just, I would like some interaction, so please put your comments in the box. Feel free to unmute yourselves and comment at this point. So Jenny and I, and also Barbara at the regional team, we are aware of 3 expressions of interest in terms of services that would like to put themselves forward for early implementers. And currently those are Hampshire, East Berkshire and Kent. But what we want to know is, are there any other systems that feel that they are ready and to put themselves forward as early implementers? Please do let us know. And please, feel free to comment at this point or put anything in the box, the chat box. And also just a bit more thought about how quickly should we implement the fast follower process. So our original proposal to the national team that they should follow at a later stage, do you think that's correct? Or do you think they should follow at the same time as the early implementers? Do you think a quarter delay is appropriate, 6 months delay is appropriate, or a year? What do you think makes sense to you if you think you would be a fast follower service? And also, what support do you think you require to become a fast follower? So either from ourselves as the clinical network, from the regional mental health team, or the national perinatal mental health team. What can we do to support you as a system to develop your application as a fast follower? Would it be helpful to have webinars or a guide to complete the applications? There will be a basic user guide, but what more can we do to support that? And if, and it's always, as we know with funding, it's a big if, but if there was funding to support this, how could we best utilise it? Would that be to provide some backfill to enable somebody within your service to take that lead for managing that process of preparing that bid? And just really want to open up to everybody to say, can you give us some feedback as to what you think would be helpful, useful, or any questions from what I've presented so far in terms of the maternal mental health services? So I want to open up to the floor. Any questions or comments? Silence.
Hi, Liz.
Hi.
It's Hannah here from Hampshire.
Hi. Hi, Hannah.
I suppose my thoughts are, from our perspective in Hampshire, if we didn't get early implementer, I would want to be a fast follower in parallel.
Yeah.
And the support, I think what you've suggested sounds fabulous, about some support to just do the application. Some webinars about that would be great. Yeah, so that's my view, that if we don't get early implementer, I'd want to be in parallel as a fast forward, as a fast follower.
Yeah, so that's one of the things that Barbara at Region and Jenny and I are working on at the moment. So with our 3 services that we know want to be early implementers, if we can't have 3, then can we push, if we can only have 1, can we push the other 2 through straight away as fast followers? Yeah, that's a really big comment. Thank you, Hannah. Any other comments from anybody else? Is there anybody sat there, you know, thinking actually we want to be early implementer and we're not on the list? Anybody else think they're ready to go? Or anybody slightly, sorry.
It's Shirley Shayler speaking from Dorset. Can you hear?
Yeah, hi Shirley.
Hi, I just wondered how did you get the expressions of interest, and I'm just wondering whether you've had conversations with anyone in Dorset, because I realise it's a bit tricky because we're not actually part of, because we're kind of falling we're kind of not part of the network, but we are part of the network, if you know what I mean.
Yeah, no, that makes sense. I'll allow Jenny to comment as well at this point, but yes, we have had previous conversations with Yagada about this, and in the last conversations we had, Yagada was quite keen to be a fast follower. To look at some of the learning from whoever were the early implementers and then to follow suit at a later stage. Jenny, is there anything you wanted to comment on?
No, I think we have tried to keep Dorset in the loop,
yeah,
because I know it's quite a sort of strange time for you guys, and that was one of the things we wanted to do with the webinars, was sort of scoop you up as well. So yeah, we have been in conversation with Yagada, and I don't think she's on the webinar today, but I will catch up with her with all the sort of latest.
Okay, thank you.
And so likewise, Shirley, if that status, you know, in terms of readiness has changed, then we would be happy to look and support that. So Dorset would, for this funding, your expression of interest would go to Southwest, but we could also support that process in order to make sure that they're aware, and that's not a problem.
Okay, thanks very much.
Yeah. Catherine Hammond's got her hands up.
Hi, I'm Catherine Hammond. I work down in Portsmouth City. It's just more for Jenny, really. I was just wondering whether PHT up at QA, the maternity services up there, have they expressed any interest or to be a fast follower? Or
yeah, the Hampshire bid actually covers the whole of Hampshire and Isle of Wight, so the whole of the LMS area.
Oh, fantastic.
So, yeah, so Portsmouth is included.
Brilliant. Thank you.
I guess that's quite an important element to raise. So as part of the application, it is very much a system allocation, application. So it will need to have sign off from the local maternity system, as well as the perinatal mental health specialist services and the commissioners. It is a properly collaborative approach and application, with everybody signing off from the different elements, and ourselves as clinical networks and our counterparts in Kent, Surrey, Sussex as well.
That's excellent, thank you.
No problem. Is there anybody slightly panicked by the thought of having to take on you know, the fast followers, feeling at the moment, gosh, we're really not ready to do this? Because that's also important to capture and understand.
Yeah, and it may be that there's an opportunity for some teams to not do either. You do have to do this by 2022-23, but you could wait and learn from other people's experience. But there's often some benefits from going in earlier in terms of the support you can get from the network, and you know, maybe some extra funding in terms of backfill and that sort of thing. So if anybody wants to have an offline discussion about it, do feel free to contact myself or Liz as well.
Yeah, please do. And once the process is finalised in terms of the approach that the national team are going to take, we will bring this back to this you know, webinar, and if not, have some, you know, specific webinars for this involving the different stakeholders, and tailor it to the needs. Say, for example, you know, we might do something separate for the early implementers and then for the fast followers, but make sure that learning is shared throughout the process. Okay. Any further questions, if you think about them throughout the webinar, please just stick them in the chat box, or as Jenny says, please get in touch with either Jenny or myself after the webinar. Okay. Next slide, please. So this was just to make people aware that there is a national webinar on the 24th of June for trauma-informed care and maternity and perinatal mental health services, which is it kind of follows on nicely from the maternal mental health services that we've just talked about. So that webinar is being held 10 till 11:30 on the 24th of June. In the slides, when you receive them, which will be by the end of the week, the actual link that says click here to join works. So you will have the link, and we will make sure that we send out, if we can, we'll forward the official invite as well. Okay, next slide, please. And just to remind everybody that all the information, so our information in terms of our resources, the information for the national team in terms of their webinars and that is all available on the future NHS workspace. We appreciate it that it's not always the easiest platform to navigate. So there are some hints onto how to get into the right space detailed here. But if you do have problems with that, then please come back to us as a team and we will point you in the right direction. Okay, next slide, please. Right, I'm going to hand over now to Yvette, who's going to talk about Webbeds and give the update in terms of the community teams page. Over to you, Yvette.
Lovely, thank you, Liz. So yes, hello, my name's Yvette and I'm part of the Hampshire Thames Valley Clinical Delivery and Networks, and I currently oversee the day-to-day of the national NHS Webbeds page. So for those of you who are not familiar with NHS Webbeds, it is a free online bed management tool for the current 19 specialist perinatal mental health mother and baby units. It's designed by and for NHS healthcare professionals and the public to help in finding a bed in a mother and baby unit anywhere across England. And we want to enable women and their families to get the help and support they need as timely and easily as possible. It's designed to tell you at a glance whether there is a bed available in an MBU that day, and if not, the likelihood of a bed becoming available over the next couple of days. It's also where referrers can download the NHS England National Perinatal Mental Health and Inpatient Referral Form. And we're quite excited because we've recently undergone some development, some of which was cosmetic, so it was just some changes to the public-facing front page. Also in the background, such as reporting functions, and as from March this year, the perinatal mental health community teams page went live. So if I could just have the next slide, please. Thank you. So I am shortly going to attempt to do a live demo, but before I'll do that, I'll just give you some background information. So we wanted to provide an accessible, comprehensive list of the contact details for all the perinatal mental health community teams across England, which, as far as we're aware, it didn't exist before we pulled it together. We really do feel excited about this new development. You know, it's been added to help women, their families, and help health professionals, not just within perinatal mental health, but GPs, health visitors and midwives to locate their nearest team. But also if a woman is moving area or visiting an area and needs some help or support. We wanted it to be easier to find the new and existing perinatal mental health community teams by listing them in one place effectively. So I'm going to attempt now to move over to the website. There is sometimes a delay, so I'm going to move slowly and hopefully you will shortly be able to see my screen. I'm hoping.
We can.
Fabulous. Okay, so before I move on to the community teams page, I just wanted to highlight that over here, if you can see my cursor, this is where you download the universal referral form. And as you can see, this is the available beds page. So for example, you can see they each have their little flag with a number. But if we click on Bristol, we can see no beds available, future no within 3 days, but also there's the contact telephone number there for those who may wish to make a referral or speak to that mother and baby unit. So to find the perinatal mental health community team page, if I click on the hamburger here and click on perinatal mental health community teams, and hopefully it will eventually load the page. So the teams are listed by region, East Midlands, North West, etc. But obviously it would take some time to scroll through. There's nearly 70 community teams listed at the moment. So we do have a search function. For example, if I wanted to find a team in Kent, I can type in Kent and it will show. Also, if you have the telephone number and maybe you want to find an email address, you can just put in the telephone number and it will again bring up the team. So I think it will find pretty much whatever details you have. It will find the community team that you're looking for. Even if I put in just the street, it will find the community team. So hopefully, we're hoping that it will ensure that you can find your community team again in a timely fashion. We would like to take the opportunity to thank those colleagues from across the perinatal mental health networks and MBUs and the community themselves for returning the details. This is an ongoing live list. We're not quite sure if it is comprehensive as yet. So if you do find that there's a team that's not listed or details missing, then please do email the generic email address that sends out the webinar communications, and we can make sure that it's up to date or contact the teams directly. And likewise, if you have any feedback or comments about Webbeds, we really do welcome all, because obviously it needs to be user friendly for everybody who's using it. So yes, does anyone have any questions? Oh, hello?
Oh no, sorry. Sorry.
Amy. Amy, if you just switch off your, that's it.
So I'll pass back to Sarah now. I don't know if she wants to share the slides again. And if there's not any questions, I'll pass over to Jenny, I think. Thank you.
Okay, thanks so much, Yvette. We're really excited about that development on Webbeds. I think that's one for all health professionals, not just for the specialist teams. We know how much women move around, and I think you'll all be able to benefit from that. And we're really pleased with that nice and easy search function. Anyway, enough of that for now. So I'm going to try and catch up. We're just a little bit behind, so I'm really going to try and whiz through this a bit. So I am talking about hard to reach groups today, and I know that everybody on this call will have considered this and will have things in place within their services, but I'm just wanting to look at it from maybe a slightly different angle. I think it's so important with all the new developments that we're tasked to do under the long-term plan that we absolutely do not leave anybody behind in terms of different groups of people. Okay, so next slide, please. So I've actually pinched this from the BAME presentation we had last time, because I just thought this was worth a little moment's consideration. So they're talking about the next phase of COVID, really. So as we move to the next phase, so like the restoration and recovery, We need to have a real focus on inequalities given the stored up pool of morbidity and unmet demand, especially for BAME communities. So already we know how much inequality there is with, you know, within systems, and but we also are starting to gather the evidence about the effect of that on particular communities. Okay, next slide, please. So what I'm considering today, and the reason that I've put this slightly odd picture in, is that I'm not sure if we actually have any hard to reach groups. I think it's about our services being hard to access. So basically, I'm thinking, who lives in that house? Is that our hard to reach service users, or actually is that our services and we're up there so hard to access? So just something to start thinking about. Could I have the next slide, please? And if we think about the things that make our services hard to access, and please put stuff in the chat box because this is not exhaustive and I haven't thought of everything, but these were just the easy wins that came to me. I mean, obviously there's still massive stigma about mental health, and I think that's one of the biggest barriers, and that needs whole system approaches. But there's also things about language and about how much of our service information we have translated and on our posters. Are we training translators? Because I think when we work with people in mental health, I worry when people are called interpreters, because we don't really want a third person to interpret what someone else is saying. For mental health, we need to know verbatim what that person says. The use of words is so important. So I think we should be training translators to so that they know. We need to know. Don't try and change it at all. We need to know exactly verbatim what that person's saying to really make sense of it. And what about the sort of culture around our services? Do our materials just show, sort of, say, white heterosexual couples? And I did do a quick look on Google, and actually I must say maternity and health visiting services are getting really good at not showing couples or white people exclusively. And I think if you went back a few years ago, that was absolutely the case. So it's making sure that we're really thinking about that. Some of it's obviously about education.
Oh, Jenny's just frozen. We will just see if we can get Jenny back. If not, I would suggest that we possibly pause and move on, and then we'll get Jenny's her system sorted again, and we'll come back, I think. Can I suggest, because I don't want to do a disservice to Jenny's presentation, so can I suggest that we move on to slide 29, and I'm going to introduce Kerry, and then in the background I will sort out what's happening with Jenny, and we'll come back to that. Apologies for the technical hitches that we sometimes have. So without further ado, can I take the opportunity to introduce Kerry and thank her for coming to speak to us today with regards to partner support calls. I appreciate this is not kind of quite in a sequential way that we wanted to do it, but thank you anyway, Kerry, and apologies for kind of fast tracking into your presentation.
That's okay, thank you. Thank you for inviting me along today to talk about our partner support calls that we've introduced. So I'm Carrie Taylor, the matron for community and antenatal services at the Royal Berkshire Hospital. Could we have the next slide, please? We really wanted to talk about partner support calls, which we introduced about the 8th of May. So the reason why we decided to introduce partner support calls was because, as you well know, nationally, pre-COVID, it had been acknowledged that work was needing to be done with supporting partners' mental health. It was an issue that we haven't really addressed, and it was certainly on our radar for this year to look at how we could improve the care for our partners. But as we moved into the COVID crisis, we found that the partners were actually receiving minimal support from us. So within maternity, we were no longer inviting men to, or partners to, scans, that they were coming in for the birth of their baby, having missed out on antenatal appointments. And once the baby was born, they were having to leave the unit and just collect their partner at discharge. When we were visiting in the houses, the partners weren't able to stay in the location. So they had severely reduced contact with healthcare professionals. So we wanted to just tap in and make sure that they were okay while keeping them safe and our staff safe. And also at the same point, we found a slight increase locally and I think nationally too in non-accidental injuries of babies. And so we wanted to make sure that we were sharing all the healthcare promotion required on keeping babies safe. And the final reason for introducing the partner support calls is that we have a number of midwives who were required to work remotely, either because they were shielding or because they were pregnant themselves. And we wanted to utilise this workforce. We know that our remote midwives are our team of midwives that are struggling the most emotionally. They often feel undervalued at the moment and like they're not playing an important part in the maternity services. And this role enabled them to fully understand that they were still of great use to us. Next slide, please. So the structure of our partner support call is that on the postnatal wards, prior to discharge, the midwives there will meet the fathers for a 5-minute discharge chat, where they will just go through any of the issues that the fathers want to raise and to take their details so that we have their name and contact number. And the partners will be advised that around about day 9, we'll be giving them a call. Also at this point, it's really important that we capture who else the partner might be. So it might be we're finding for some families that actually there might not be a biological partner present, but that the support might be the grandmother. And so we will therefore then take her details and her phone number and make sure we offer her support. And again, really importantly, if there is no partner around, that we don't make any insensitive calls to them around about day 9. The following day, we then text the partners and just let them know when we will be calling and roughly what time, so that they can keep that time available for us and record all this information on an electronic diary for the remote midwives to use. Around about day 9, then we will contact them, and we have a script that we have for the staff to use, just so that we're being equitable in what we're saying to all partners. And we have 3 points of focus. So the first issue is we want to check that the partners are feeling emotionally well, and then we can give them guidance on who to call and where they need to refer themselves to if they are struggling. And if they feel unable to do that referral themselves, then we're happy to help with them and do that for them. We then give them an opportunity to ask us any questions or raise concerns. And finally, we finish off with talking to them about parent safety with a particular focus on the ICON recommendations. If you could show the next slide, please. So the ICON recommendations are, I'm sorry if you're already familiar with this, but basically it's an organisation that has helped fathers or partners to be able to cope with crying babies. So it's really focusing around explaining that crying is normal and that this will peak around about 2 weeks and remain fairly high for about 8 weeks. that's why the timing of our call is on day 9, so that we can then prep them for the fact that, you know, your baby might start crying a bit more in the next few days, and that's fine. We offer them comforting methods, so we talk to them about how they can soothe their baby safely and things that they can try to do to placate their baby. And finally, thirdly, we will then talk to them about the fact that it is actually safe to leave your baby crying, as long as they're in a safe place that you can walk away for a few minutes and calm down. And finish off with absolutely making sure that nobody should ever shake the baby, and being quite honest about what shaking babies can result in for families and for babies. Next slide, please. So far, we started this service on the 8th of May, and we have managed to call about 550 partners. We have 7 days a week a midwife dedicated to this service, and she will phone approximately 14 partners each day. They're allocated 30-minute slots for this call and for updating our electronic systems. Most of the partners have been really receptive to the call and are very thankful for the extra support offered. So far, none of the partners have actually raised concerns about their own mental health. One partner had raised concerns about the mother's emotional well-being, so we were able to step in and offer some extra help. And what's really interesting is despite all parents being told to call us if they have any problems and need more support, we found that it was actually the men at this appointment, at this phone call, who were saying that they were struggling with feeding issues, and we were able to offer some extra visits and support for them. And the men seemed particularly reassured about the fact that it was okay to leave a baby crying. And then we've just got a couple of comments there from dads that we've been in touch with to see how they viewed the support phone call. Next slide, please. So feedback from the midwives, actually they are really enjoying this role, and they do feel that they're making a massive difference to families. And again, you can see there just from 3 of our virtual midwives how they've enjoyed the experience and the difference that they feel they're making. And again, we have found that many of the men have used this opportunity to talk about what the birth experience was like for them and to ask questions. Many of them have praised the services they've had. A couple of them have raised issues, and we've been able to make sure they know how to address those concerns. Next slide, please. So our future plans is we would like to do a more detailed audit at the end of July, just to see really truly how beneficial this service has been over the last 3 months. Our plans at the moment is, while we have virtual midwives, that we will continue to offer this service until we feel it's no longer required. And in the long term, it's really truly about how do we address the support that we provide for partners during pregnancy and beyond. And that's a massive piece of work that this literally just tips the iceberg with. That's me done.
Thank you very much, Kerry. Any questions for Kerry or comments? There's some in the chat box. Gisela, would you like? You've got your hands up.
Hi, just to say, I think that's phenomenal work, and obviously it's come out of our control scenario with COVID and the restrictions, but something good seems to really come out of it that's so valued by partners. And I know that the others, a lot on this group, know that we've been trying to set up a father's wellbeing group that teaches them CBT skills and dealing with their anxieties and a low mood during pregnancy and after. And so the difficulty we have is, where in the community do we advertise it? And I think it used to only be like women have to tell the men, because they're quite a hard to reach group, the men, but actually through the community, like what you've just said, through the midwives, etc., that would be an ideal place for IAPT to be signposted, you know, for the men to get. So for our group, it's actually run virtually now, so it'll be running East Surrey, so we would cover Surrey, so East Surrey people, men would be able to benefit, all women, other partners, would be amazing. So it's kind of run virtually, and that's our constant challenge. So it's come through psychiatrists trying to refer in perinatal teams, but actually I'm wondering where else they could be aware that that support is there, even up to the child being 2 years of age.
Yes.
In these groups to gain confidence, because yours are so appreciated, so they really need it. There's a lack, isn't there?
Yeah, absolutely. And midwives are your perfect forum to, you know, to promote those services that are out there. I think we all do feel at a loss as to what can we offer the dads. And we do know that the dads are more receptive to the electronic versions of health promotion. So definitely tapping in with your local midwives and asking them to support your cause would be a good route for sure.
Thank you.
Thank you. Just looking at some of the questions. Sorry, they've scrolled on a little bit, I think.
I know there was one from Jules asking if the resources could be shared.
Yes, absolutely. Anybody who wants the resources to be shared, we'll share everything with you. If they just want to email me and we'll share the script that we use and the process, they can contact me and we can talk through how we set it up. It was literally set up in about a week. It was very easy to do. And yeah, anybody who wants any information, just email me and we'll happily share.
Thank you, Kerry. Just scrolling through and looking if there's anything else. Lots of fantastic comments, and rightly so.
Oh, thank you.
Thank you very much, Kerry. That's a great.
Will you share my email, or shall I pop it here?
If you could put it in. Well, actually, we can share it with the slides. Are you happy for us to add it to your slides?
Yeah,
lovely.
Brilliant.
And I know there was a question in the box about the slides, so we do always circulate the slides after the webinar so that you have them. And you can disseminate further as well.
Brilliant.
Okay. Thank you very much.
Thank you.
Now I'm praying that Jenny might be back online. Is Jenny back?
Yes, I'm back.
Fantastic.
I'm so disappointed that I missed some of that. It sounded amazing.
Great, absolutely great presentation. So thank you very much, Kerry. Right, I'm sorry we stole your, or the internet stole your thunder in the middle of your presentation.
Well, I feel very de-skilled now. That was just such a interesting thing. So okay, I'm going to just pick this up, and I am going to whiz now because I think we're a little bit over. But
Jenny, you're okay in terms of time. We've got up to 11 o'clock, 11:05. So
okay, could we just go back? That's it. Perfect. What I would say on, just to finish off with this slide, is something that's a massive bugbear of mine. If we look at the bottom bullet point, I'm just thinking about, so if we take armed forces first, I think that both the serving soldiers who are women and the partners of serving soldiers, I do think they're terribly underrepresented in our services. And speaking as somebody working out of a Hampshire service, you know, there's a massive armed forces presence in Hampshire. So I think that's something that we really need to improve on, because I know they've got a lot of markers for potentially developing mental health problems with isolation, etc. And Ruth Guest, who is a military GP, has done a marvellous piece of work called Rebalance, which is about sort of bridging the gap between military and NHS healthcare, particularly focusing on perinatal. It's not actually published yet, but any day soon. So I'm hoping we can get her to come and talk about that specifically at a subsequent webinar. And the thing that I've put there about white middle class women is that I do think that there's a group there who, although they might access services, they don't really necessarily engage with services. They're very socially skilled. They're very, very clever at keeping health professionals at arm's length and only letting you know exactly what they want you to hear. And we have done some work in Hampshire Thames Valley, some training for maternity support workers called I'm Fine, and it's about getting behind that mask that women present with, often saying everything's fine, no problems, because they are actually quite a high risk group in terms of perinatal mental health, I think probably because of all that covering up. Okay, next slide please. This we don't need to labour on. You all know this, and I obviously dads are in there, and I would have, you know, led on to Carrie's marvellous talk with a seamless segue there, but it doesn't matter now. That's the internet's let me down. Okay, next slide, please. In terms of what can we do about it, I think this piece of work from IAPT is something that could easily be lifted and used with perinatal services. So what this is saying, first of all, about improving access, is that you have to know your community that you're dealing with. So you need a baseline audit of particularly with ethnicity, so of the women who are accessing your service, but also of the population in your community, and you need to find out where the gaps are, and that's absolute basic stuff that every single team should be doing, because once you know where the gaps are, you can address them. And okay, next slide, please. And then the IAPT Positive Practice Guide goes on to cover adapting therapy, improving engagement, workforce and staffing. And I think one of the really exciting things that I thought, yes, we absolutely need this as well, is comparing the outcome measures of women from BAME communities with other women who have accessed services. And I think that would be really interesting, because it's not just about have we found them, have we engaged them, but are we doing the right things for them? You know, is it the same? Do we need to adapt staff? How would we adapt that therapy to make it work? So really thinking flexibly about what we need to do. Okay, and my next, and I think my final slide. This is a very newly published piece of work, which has just gone out and asked services various questions about perinatal mental health during COVID. And this is really worth a read if you get the time. If you're thinking about how to access those hard to reach groups, there's a lot of good stuff in here. And I would recommend just having a look. There's also examples of what other services are doing. There sounds like there's a really interesting audit going on from a service, Oxley's. So I think that's definitely worth a read. So that's basically, it's nothing that you don't know already, but just to start focusing some discussions around getting these services right, not just in terms of the expansion of the long-term plan, but making sure that that access is there for everybody. Okay, I think that's the end of that one. So I now don't know what's coming next because it's gone out of order.
That's fine. Jenny, questions in the box. So Jenny Hughes has asked about whether there's been, have you engaged SAFA for the armed forces?
I don't think we have, Jenny, in our service. I believe Steph, the lead for hard to reach groups, as we're still calling it, is on the call, so she can probably clarify that, but I'm not aware of it. So that's good. Thank you for highlighting that. And thanks, Sarah, for answering about the publication.
And we'll make sure the full web link to the document goes out with the slides when we circulate them. Lovely. Thank you very much, Jenny. We're now going to move on to the collaborative session, which Jenny and I will run together. Can we have the next slide, please? Sorry. Yeah. Thank you. So we are really keen to capture the great work that you've been doing and thinking about some of the new initiatives that you've implemented. What would you want to amplify and spread and share in terms of moving forward to become new practice going forward, really. What are the things that you had to implement because of COVID, but actually were a temporary measure and you would want to stop? Anything that needs to be kick-started, restarted, that had to be paused temporarily. And we just want to capture some of these innovations. And this is a piece of work that's being done both regionally and nationally. So what we are doing with the regional South East Maternity Cell is capturing both the maternity innovations, and then with Barbara Goss at Regional Mental Health Team, we would like to capture the perinatal mental health specific innovations so that we can share that together and share more widely nationally as well. So we just wanted to really have a discussion with you all in terms of some of the innovations that you yourselves have talked about within these webinars or have been presented, and open it up really to have a discussion.
Yeah, and I think what I might just like to add is, don't just think we're after those really high level things. It could be some of the really little things that you've done that have made a difference. So think of it, you know, across the board, really. I think it's so important to capture it. Okay, so Becky, thank you. Remote working will be continued and become part of our usual working practice, reducing travel and supporting clinicians. Some roles will now be home-based almost completely, whereas they were office-based. Yeah, I think that's going to be played out across a number of services, Becky. Sorry about that.
Still go today.
It's not my day, is it? But yeah, I think, are there any particular aspects of that that you'd like to highlight? I know a lot of people moved groups very, very successfully online and virtual.
Jules has just commented on that. So yeah, the remote support groups for women for delivering antenatal education, but also widening access to support with mental health. Absolutely would agree with that. Some great work that's been done in a very short space of time to get them up and running.
And I don't know if Joseph is still on the call, but I know that you've done something that I thought was really lovely. Yeah, come on then, Joseph. Tell us about what you've been up to with your Tea with Teams.
Hi, Jenny. So we do have what's called Tea on Teams. We're running that every day, Monday to Friday, actually, at 10 o'clock. So mums can come in. It's a drop-in session. They can come in and have time with our nursery nurses or, you know, our support workers, and sometimes our clinicians as well. So they know that it's just there for them to access, so they can come in anytime. We run virtual groups on there as well. So there's different themes daily. So, you know, the uptake is good sometimes it's not, but you know, there are some mums who are really keen on attending such groups. So it's something that we really want to develop, and we will continue to develop that and just give more access to mums. I think it's fantastic. It's a fantastic opportunity, really.
Yeah, and I think one of the lovely things about that, Joseph, is that it's not structured, and I think there was definitely a place during COVID for a space that wasn't structured, where you could just go and talk about anything. You know, you don't always have to have a massive agenda to be able to support women. I think that's another thing we've learned, isn't it? Sometimes it's just about being there and listening.
Yeah, so that's something that we are doing here in Buckinghamshire, and yeah, we just want to develop it and, you know, see how it goes, really.
Brilliant.
Great. There's some great things coming in the chat box. Please keep them coming. We'd really like to capture as much as possible, because we know the great work that you're doing. So Jules has put about the successful anxiety management antenatal group. We've also got partnership working with local authority colleagues, which is so key, isn't it? Real focus on the unborn and under ones. Thank you for that, Shirley.
We might be after you for a presentation on that.
I think we will.
We have a safeguarding theme down the line, Shirley.
More bespoke teaching sessions to stakeholders and better attendance. I think that's something that we've recognised, that you can reach a far bigger group by doing it virtually. Question from Christine in terms of, is anyone using email as a way of communicating to a wider group of people? Thinking about email could be a way to stay in touch with people in terms of groups and courses. Any comments on that?
Just from Hampshire, I know that we've been sharing a lot of resources with our mums via email, which they've quite enjoyed. It's quite a lot to retain from a video or a telephone call. So we've been using it in that way. I don't know if that's what Chrissy's been, what Chrissy was asking, but yeah, we certainly are sending lots of resources to our mums via email.
Thanks, Stephanie. And Dawn's got her hand up. Dawn?
Similarly with our Knowing Me, Knowing You groups that are run virtually, we send on the information that we talk about in those groups to them by email, and that seems to be working really well as well. And of course your virtual groups themselves, Dawn, are very well, very important to mention here, aren't they? They're going really well. We're expanding the groups now. We started with a pilot of 6 and we're expanding that so that we'll have 13 in Hampshire until through to August. We're just getting the new ones up and running. So they seem to be well received. I mean, you know, we're still learning from the pilots, but they seem to be well received by mums.
That's brilliant.
Yeah, I think seeing your comment, Becky, about compassion focused therapy continuing online, I think the groups thing has been really fascinating, because there's so much that pre-COVID we would have said you can't possibly do that virtually. We have to see people face to face, and we wouldn't have tested it out without COVID, because we would have been adamant that these things couldn't happen, whereas now we've had to. And actually, some of it has been really, really interesting and valuable, finding out, yeah, it does work online. And actually, we don't need a creche, and it's a lot cheaper and it's more accessible. And we don't have to find that place in a patch that everyone can travel to. We can offer it much more broadly. So I think we've learnt so much in such a short amount of time. Oh, and Dawn's saying in the chat box that Health Visiting have enjoyed Steph's presentations online, so so that's really good.
And Christy's asked Becky for some more information. I think any information that you're willing to share with us, we would like to capture so that we can send out to everybody with then kind of key contact details, because it's such a great resource across the patch. Virtual health visiting.
Mindfulness antenatal classes on Zoom. That sounds really interesting. Right. I don't know, Nicola, what discipline are you? I can't tell.
Can you hear me okay? I'm a midwife at Oxford, and we've been running antenatal mindfulness classes since 2014, and we'd have always thought they had to be face to face. And we will still run face to face, but we can reach many more people, and it's been very successful.
Gosh, there's so much.
It's great stuff. I think has Gisela got her hand up?
Yeah, just to say, I find that fascinating about delivering that to women remotely, and it is successful, because during COVID we've had one of our fully trained MBCT mindfulness members of staff actually do it for staff.
Yeah.
Time, so he does a half-hour session, and that's really helped us all with our well-being, and we do that every week, once a week, for half an hour. So if it can be done with staff, it can be done, you know, with the public, and it's certainly something that we're going to take forward to discuss to help women in our areas.
And I think that's also really important as well, capturing the innovations that there's been about staff wellbeing. There's never been more of a focus on how do we ensure that our staff are okay. So I think it's really important for us to capture that and not lose that post-COVID, but make sure that we really support our staff. So please, any of those about staff wellbeing or would be really great as well to also detail.
Yeah, does anybody else want to put any sort of staff wellbeing stuff that they've been doing in the chat box? As usual, with a whole bunch of health professionals, much better at thinking about what you do for others than what you do for yourselves.
Staff mindfulness.
Oh, there we go. Lovely. Yeah.
Right,
and I know that that's been happening at Southern as well, so that's really good. Yeah.
Okay. Is there anything that anybody wanted to share as well in terms of things that they are oh, that's great as well. Sorry, I'm just reading the chat. I'm getting excited as these are coming through in terms of safe rooms, mindfulness sessions, weekly anxiety groups. So important. Psychotherapists running sessions for staff, and even a virtual session for remote workers. Fantastic, really good stuff.
And Carrie, your whole presentation, I think that needs to be mentioned as well. You know, that innovation is amazing.
Okay. And I was just going to ask a question in terms of anything that has paused because of COVID, and there obviously are elements that have paused that you would want to reinstate from previous ways of working that actually you're desperate to get going with again. What do you think from that? Or do we love our new way of working? I guess that's the other question.
I suppose I would have to say that I'm really keen to get going again with the long-term plan, because I think there's so much in there that fills gaps for women, and I'm quite excited for the implementation of a lot of it. So I'm really keen for that to get going again.
Cake. That's the important thing, to get people. that's all staff wellbeing with involve cake, and I'll be there. Yeah, I think Becky's comment about seeing each other in person and socialising, you know, particularly our clinical teams. There's we are like our own little families, aren't we? And so it's really nice to have that, and that's something that I think many people will have missed recently.
Oh, okay. And Nicola's saying that both afterthoughts has been limited. Is that because of the demands on the service, or sort of extra demands due to COVID, Nicola, or is that something that was much more difficult to do virtually?
We did have less time, but it's really the women prefer face-to-face in person. They can see their records, and it seems to work better for some women. We've done a telephone service and going to start more video service to see whether we can meet the gap until we restart. But we certainly need face-to-face, but we don't have any room.
Oh, okay.
Yeah, the demands on the clinic rooms are high with all the drop-in community services. We can't bring them into our hospital wards.
Okay. And
the health visiting, picking up 6-8 week review, absolutely really important. Once staff are back. I'm liking the plan for the socially distanced team picnic. That's fantastic.
Yeah, perfect.
Okay. Yeah, they put a lot around personal interaction. Okay, there's some really great stuff. Please do feel free, continue to be putting stuff in the chat box. And also Friday night team quiz, fantastic. And a regular pet party. Gosh, our team would like that. That we're all dog lovers, so we're regularly sharing pictures of our dogs. And NHS England actually have a space on their website for COVID companions, which is all the pet pictures. So that looks great. Keep them coming in. Right. Well, we have time to spare, really, which is very unusual for us. So we're happy to have further discussions about the restoration and recovery. We will be moving on to the long-term plan, as I say, for the next webinar. Can I just have the next slide up a second? Oh, those were our discussion points. Sorry, we've worked on the diagram. Now, this is a very, very wordy slide, and I apologise for this, but I've literally taken it from the national team. And really, because I just wanted you to have the detail when it comes out and it's circulated. But just to let you know, in case you're not aware, there is an innovation survey out at the moment for completion by the 30th of June. There's a letter that accompanies it. It went out to the system either Monday or yesterday. I can't quite remember when it popped into my inbox, but it's from Steve Powis as the National Medical Director for NHS England and Improvement, and also Hugh McCaughey, who is Head of Innovations, I think. I hope I've got his title right. And they want to capture the beneficial change. So exactly what we've just been talking about. The survey is going out to clinicians, clinical leaders, the Royal Colleges and professional bodies to capture everything from all the different stakeholders. And it's based around 4 questions that are listed there. So what beneficial innovations and changes have occurred in your specialty and within patient pathways? Please describe the impact of these innovations and changes in terms of population health outcome, patient outcomes, safety, the wider system, efficiency and productivity, and how did you measure the benefit? What is needed to sustain any change? And what, if anything, hasn't worked so well? I think it's also really important for us to capture the things that we tried but actually haven't been that successful. The link is on this slide here. Hopefully many of you will receive this letter and survey into your inboxes, but you can also go to the link there in order to complete it. And they're asking for replies as soon as possible, but at the latest by the 30th of June. And we'd be really keen. Obviously, we will also feed up your innovations via our channels, but if you can go and do the survey, it would be a great way to capture it as well. Just looking at what's coming through in the chat box, I think Janet's got a really good comment in terms of being helpful to look at the restoration and recovery alongside a SWOT analysis. Absolutely agree. Yeah, that's a really good comment. Okay. Any further comments from you, Jenny?
No, I don't think so. I feel a bit discombobulated with losing the connection. So I think I'm sort of back with you all, but I've sort of lost my thread a bit today.
No.
So yeah, I think there's just been some amazing stuff coming up in the chat box, and it's just so great the way everybody's just embraced this. And I think what I've loved is that autonomy that everybody's shown, and how some of the artificial barriers that are there just got broken down and completely ignored, and people have just got on with all this amazing stuff. And I think you all need like a massive round of applause, because it's just been amazing. And to read everything, you know, how it's the NHS at its absolute best, I think. Well done, everybody.
I think that's something that I've heard talked about this week, actually, by the national teams, that with a lot of their transformation programmes, there is the hope that it offers the ability to break down barriers and to, you know, work across systems and, you know, really take those leaps of faith in terms of pushing things. But actually, COVID has enabled us to do that. We're often still constrained by you know, the governance situation or whatever, and COVID has just allowed us to kind of break down those barriers.
Yeah.
Okay.
And if we have a think about what normally gets in the way, clustering, so and things like that, it might be a good time to say, you know, do we have to keep doing this because actually we've got a lot more time to do something a lot more beneficial.
In terms of these innovations as well, I would like to plug, I know we don't always blow our own trumpets, but I mean, the Health Service General Awards have just about, I think they closed this week, but I would really like, I encourage services to think about these great innovations and thinking about applying for future HSJ awards or other awards within your trust and that, because these are really good things to capture. And as Jules says, really capturing innovations and allowing people to shine at their best. Can I have the next slide, please, Sarah? So going forward, we're going to be taking more of a focus on the long-term plan as that comes up and running. We would like you to think about what training you need in order to support delivery of the long-term plan. So probably for today, it's food for thought to bring back to the webinar next time. Obviously, on an annual basis, the clinical networks normally receive funding from Health Education England in order to provide training across both specialist and maternity services and wider for perinatal mental health. And many of you have hopefully benefited from going on those different training courses. And we've also got the national course coming up in Winchester on the 9th and 10th of July, which many of you will be doing virtually. Just to let people know, thank you to those who asked for extra places within the Hampshire and Thames Valley patch, and we will be coming back to you imminently to let you know whether you have secured a place. But please think about what training support or what training needs you have going forward. We are keen to capture that, as money often comes down with very limited time to put in bids. So if we have a wish list of what you would like, we are ready to go. Thank you. Next slide, please. So just to remind you that the slides and the resources will be shared following the meeting. If you've been forwarded an invitation to this webinar, please let us know via that email address so that we can get you on the distribution list. Next slide, please. And the next webinar will be on the 1st of July. Looking at the NHS long-term plan. Our plan following that webinar is then to look and take different areas of the long-term plan on a consecutive basis to kind of go into further detail on them and work through with yourselves. And next time, so again, just to think about it, we're going to be asking whether the frequency you would like us to continue with the webinars, whether you want us to continue with fortnightly or look to monthly. So again, just be starting to think about that, and obviously we want to tailor the webinar to what works best for all of you. Okay, so I think you've got 8 minutes to either go and get a nice cup of tea or have a comfort break before you get back into your busy days. Thank you all of you for joining us today. We do appreciate your input, and you know, just some fantastic work going on, so well done to everybody. If there are any last questions, please do feel free to ask either in the chat box or opportunity to speak before we finish the session. Otherwise we'll say goodbye to everybody. Lovely. Thank you for your time, everybody, this morning.
Thanks everyone. Bye-bye. Bye.